And this was the ECG which was recorded. The rate is 150 per minute, the ventricular rate. So there are three questions. Is this sinus tachycardia? Can we go to the not polling. So A, yes, B, no, or C, could be. So you can start sending your SMS now. Can you go back to the... Remember, it's 6A, 6B, 6C. 6A, 6B, 6C. 5 more seconds. Okay, everyone has sent their response. Anyone remaining? Message sending failed. Why don't you do one thing? Just go to him, you write down on a piece of paper and keep his name and for this particular message. Okay. So if we discuss this ECG, by itself the ECG shows a P wave preceding each QRS complex. In fact, if I can use the mouse, we can see a normal P wave. I call it normal because the P wave is positive in 1, 2, AVF, V4, V5 and V6. So 6 leads which need positive P waves have positive P waves. So yes, it could go as a sinus P wave if we look at the ECG in isolation. But there's one more sign on the ECG which is interesting, which is QRS alternans. If you look at lead V2 and several of the other leads also, there is QRS alternans which to my mind has not been described with sinus tachycardia. Anyway, even if we leave QRS alternans aside as a minor point, the fact that the patient has incessant tachycardia, and this is where we say the correct answer, if we look at the ECG in isolation, could still be C, that it could be sinus tachycardia. But if you have a person who's having incessant tachycardia for no obvious reason, it can't be sinus tachycardia. Sinus tachycardia is never incessant. So the correct answer has to be no. This is not sinus tachycardia. This is not sinus tachycardia. The simplest way to confirm this would be to check this patient's pulse rate during sleep. If one can't do that, you do a 24-hour Holter. And if there's incessant tachycardia, it can't be sinus tachycardia. In fact, can we go to the next slide? So the correct answer was atrial tachycardia, because in the algorithm in the talk on narrow QRS tachycardia, it's pointed out by Sriram that if you have a P wave preceding the QRS, the most likely is atrial tachycardia, especially with a positive P wave in lead 2. Now this shows the 4 chambers of the heart in the left anterior oblique view, and the catheter and the arrow shows this is where it was found that the tachycardia was originating from. Why I'm showing this is that if the atrial tachycardia originates high in the right atrium, like it is here, high in the right atrium, the P wave will look like a normal P wave, because the sinus node and the tachycardia focus both are not very far from each other. Next slide. Yeah, that's a point which I think is well taken. And in fact, if you look at this slide, your point is validated, because this is a slide during radio frequency energy delivered at that spot, and you can see an abrupt termination of tachycardia and sinus rhythm at a normal rate restored. And if we compare the P wave during sinus rhythm and the P wave during tachycardia, in most leads it looks identical, except, as Amit said, there are differences in V1, where in sinus rhythm it is mildly positive, at least it's not clearly negative as it is during tachycardia. But other than that, in lead 2, the P wave is more positive in tachycardia than sinus. There are minor subtle differences. The message here is that this was an adult who could complain of palpitations. There are children, infants we have seen over the years, and I'm sure all my colleagues who are electrophysiologists will have seen these, who are labeled as cardiomyopathy because children don't complain, small children don't complain. The mother doesn't notice, she notices the child not well, the pediatrician or the GP thinks there's a cough, cold, keeps treating, till the stage comes when the child becomes breathless, and then they say, oh, let's get an echo, and then there's cardiomyopathy. And I've seen children for 3-4 years going on, coming with given up as end-stage cardiomyopathy. It was all incessant tachycardia. And the atrial tachycardia. You eliminate the atrial tachycardia, and then it's thought it's sinus tachycardia. You eliminate the tachycardia, you can cure the cardiomyopathy. I think that's the most important. Don't miss this in children. Adults will complain, small children won't. You want to add anything, Dr. Green?
No, I think that's a really good point. I think the only way you'll ever know whether a cardiomyopathy is a tachycardiomyopathy or a combination of cardiomyopathy and tachycardia is to fix the tachycardia. So tachycardia is never going to be good. So you have to fix the tachycardia, and you would be surprised at how many of these people end up with completely normal LV function.
Next. Yeah. Yes. Yeah, that's a good point. Inappropriate sinus tachycardia, first thing is not incessant in many people. I mean, there are two types. When you say sinus node reentrant tachycardia, which exactly looks like, is not incessant. But inappropriate sinus tachycardia can be incessant, like this, and sometimes responds very poorly to therapy. Beta blockers would help, but sometimes responds poorly to therapy. And the point is, suppose you had only this ECG, you could even call it as incessant inappropriate sinus tachycardia. So, no, but based on the ECG you couldn't, but if you did a 24-hour Holter, you don't get incessant inappropriate sinus tachycardia. Dr. Green, what do you think?
I totally agree. I think if you do a 24-hour Holter on the person who has inappropriate sinus tachycardia, you see substantial variation at nighttime during sleep, including heart rates that come down to 60 and 65. So yeah, though it's very different, it's not incessant.
Yeah. Narasimhan, this thing take on the QRS alternancy? I found that funny, you know. Can you, if you get sinus has anybody heard of QRS alternance in sinus tachycardia? Normal.
So QRS alternans in sinus tachycardia obviously should make you think of pericardial effusion, usually malignant.
Yeah.
So QRS alternans with sinus tachycardia is a very important sign of tamponade or large pericardial effusion. QRS alternans during atrial tachycardia has definitely been described, and in our original series there were a couple of atrial tachycardias that showed QRS alternans.
Oh yes, Dr. Green was one of the first to publish the value of QRS alternans. How can I forget that? Next slide. And after ablation, this is just a slide to show we gave isoprenaline, we did very rapid pacing, we couldn't induce any tachycardia, and she was cured. Next slide. No, go to the presentation. Stay on the presentation. Yeah.
So here we see,
Okay, keep this. It's okay.
So here we see a pause, and the question is why the pause? So we see two sinus beats followed by a pause, two sinus beats followed by a pause. And the alternatives are sinus arrest, AV block, block PAC, or SA block. So pull out your phones, and this is question number 7.
You have it in your booklet. You have those small booklets with you. You know, we just realized we can't show you the main presentation because I don't know if the smart people in the audience noticed he's put an asterisk on the correct answer. So he's actually removing the asterisk before showing the main presentation.
If they're smart enough to notice the asterisk, then I think they should be allowed to get it right.
Okay, sorry for the delay. He's removed the asterisk from all the questions. So now we can show this. So 1 sinus arrest, 2 AV block, 3 block PAC, and 4 SA block. So what is the number of this question? 7A, 7B, 7C, 7D. So you can start sending SMS now. 7A, B, C, D. Okay. Anyone left to send their SMS? I think everyone has sent the SMS. Dr. Green?
So the commonest cause of a pause is a blocked PAC. And the problem is you can't always see the PAC. You have to look for it. So where you look, if it's not obvious, is in the T wave preceding the pause, and you compare it to the other T wave. So if you can just hit next on this, please. We've blown that up, and hit next again.
Next. Next.
And you'll see now that in the second T wave, there's a sharp high frequency notch that you don't see. There it is. And if you look in the T wave preceding that, you don't see it. And again, you look at the T wave after the pause, you don't see it, and then the next beat, you see it again. So this is a blocked PAC. And this is the most common cause of a pause. Again, this is not heart block. And it is sometimes not so easy to see, but you have to look for it.
I think the important thing is these patients are misdiagnosed as sick sinus syndrome. And sometimes with, some symptoms like some giddiness or some are even gone for unnecessary pacemaker implantations. So the important thing is if you recognize it, you know it's benign. So don't fall into this trap. I'm sure Narsimhan, Sriram, you must have seen patients referred for a pacemaker or worse, having already undergone a pacemaker for blocked PACs. Next slide. Next. Yeah. No. You just tell me the question number. Don't keep changing the presentation. Just go there. Which one? Answer was C. Okay. So this is a young lady with recurrent rapid palpitations and sometimes near syncope. Normal echo. Question number 8. So you have the arrhythmia on the left and the sinus rhythm on the right. The question is question 8. So A, SVT, B, VT, C is pre-excited tachycardia, and D, of course, you can poll. It's like the new polling system in India. You won't be called the correct answer, but at least we'll know how many of you find this too difficult. You know, now in the elections, you'll be allowed to say, I don't want to vote for any of the candidates. Okay, so start voting. You got 5 more seconds. This is not the answer, okay? Why are you going on this? You remain on that. You remain on that. Yeah. You just remain there. Just I'm telling you 8. It's okay. It's okay. Okay, everyone's voted. So this is clearly a wide QRS tachycardia. It's a wide QRS tachycardia. And it shows a right bundle branch block like pattern, lead V1. However, in V6, there is a deep S wave, which is unusual for right bundle branch block. An S wave which is so deep that the R by S ratio is much less than 1. And the most important is the limb leads, which show you an extreme left axis deviation. The QRS axis is minus 90 degrees. This is a young patient with a normal heart. This sort of tachycardia is typical, is VT. The correct answer is ventricular tachycardia. Next slide. The reason why it's misdiagnosed as SVT is it occurs in healthy young people, is well tolerated by and large, and it responds to verapamil, it responds to diltiazem. So more often than not, even in the year 2013, this is diagnosed as SVT. But this is classically fascicular, left ventricular, idiopathic VT. Dr. Green, you want to make a point?
Can we go back to the ECG?
Can you go back?
You know, one of the criteria that we use, actually almost all of the criteria that we use to differentiate SVT from VT has to do with morphology of the QRS, and the morphology really has to do with activation through ventricular muscle versus through the Purkinje system. So idiopathic VT, unfortunately, doesn't make any of those criteria because it's actually activation through the Purkinje system. So the initial activation, if you see these, is very sharp. And the late activation is slow. Whereas in the Brugada criteria and all the other criteria, what we're looking for is slow initial activation. So this is one of those that can fool you because initial activation is Purkinje. It is rapid, it is sharp, and it is the opposite of what we find with most morphologic criteria. So this is one of those that can fool you, but this is, you know, I think you have to commit this ECG to memory and create a template because probably 90% of the fascicular VTs look exactly like this. Right bundle, left axis with predominant S waves across the lateral precordium. They look exactly like this. Occasionally you see ones that originate in the left anterior fascicle, but this is 90–95% of them. So memorize this ECG because almost all of them look like this, and you may get it wrong.
Next. Yeah. So elderly lady who's again having pauses is question number 9. 9A, sinus arrest. 9B, AV block. 9C, sinoatrial, SA block. Start sending your SMS. 9A, 9B, 9C. 10 seconds to go. Everyone send them? Anyone remaining? Okay, we are done. Stop receiving. Dr. Green?
So when you see this perfectly regular rhythm and then a pause, and the pause is twice the PP interval, that suggests that you're actually, and again, that suggests that you're actually missing a P wave, but there was a sinus node activation. So this is SA block. Keep going, hit it again, advance. And I want to show you, this is the only case I've ever seen of this, but this is telemetry on the ward. And you see just on the top strip, you see again one missed P wave. It's a P wave that's missed, not a QRS, right? So it's SA block, not AV block. On the second strip, there's one that's missed. On the next one, there's none. And you can see that that is perfectly regular. Go on, next again. And I want to show you what happens next to prove the diagnosis. We end up with 4 to 3, 5 to 4, 4 to 3, and then 3 to 2 near the end of the strip. And after that, we have 2 to 1. So this person ends up with sinus bradycardia at a rate of in the 30s, and it's really 2 to 1 sinoatrial block. And if you just saw that bottom strip, you would never know, without all the other information, that that is 2 to 1 sinoatrial block. But I think when you see this whole progression, you can be very convinced that this is sinoatrial block. So sinus bradycardia can occasionally be, and I have no idea how often it is, can occasionally be 2 to 1 sinoatrial block. I thought that was a fabulous case with 2 to 1 sinoatrial block. I've never seen a progression quite like that, but I think this is proof.
Sure. Next. Okay. This is 10. This is number 10. We won't change screens, we'll remain on the screen. So to give you a little background, this was a lady who underwent a permanent pacemaker implantation for symptomatic, what was called degenerative AV block. Her echocardiogram was normal. The pacemaker was a single chamber pacemaker. It was uneventful. The patient was brought back to the ICU. Next day onwards, the patient started having arrhythmias and recurrent cardiac arrests. The electrolytes were normal, and she was shocked several times for cardiac arrest. This was the ECG, and I think we have to go to the presentation because the choices are not seen here. Go to the quiz, the choices. So the question is, what does the ECG show? Yeah. So 10A is abnormal pacemaker function, 10B is monomorphic VT, 10C is torsade, and 10D is artifacts. So it's okay, you can leave it here, it's fine. This is pretty obvious what we are seeing. So you can start voting 10A abnormal pacemaker function, 10B monomorphic VT,